Hello guys, I am Dr. Mukul Mohindra, your orthopedic instructor here at Unacademy. And in this special session, I am here to actually discuss some clinical questions with you. And the topic that I've specifically chosen, that is on the bone tumors. So this is the topic I've chosen, and I'm going to discuss clinical questions on this particular area with you. Fine. All right. So let me just start with the first question. And why clinical questions? Because I think you very well know that you are almost about to enter into that era of the next exam, and next is all going to be about the clinical scenario. So it's very, very important that you understand the pattern of the next. So that's why I've specifically taken up the clinical questions for you. All right. So I'm starting with the first question. 6 years old girl. She's presented to you with history of episodic fever, and this has been coming almost since a month. So 6 years is the age. You have history of fever that's been coming since a month. Now she can also feel a palpable mass in her mid thigh, mildly warm also. Okay. Her TLC is mildly raised. ESR is quite raised, and the patient seems to have anemia as well. All right. Uh, the X-ray picture is given, and I hope you can note this periosteal reaction with bone destruction. Perfect. And the biggest hint, you have the biopsy. That's generally the gold standard from the field of bone tumors. And that's the biopsy that's shown in front of you. I hope you can see multiple blue cells. So what the examiner has asked you after asking so much about the prognostic factors. So this is the clinical history that is given, and the examiner wants to know which of the following will indicate a bad prognosis. Now please understand the pattern you are going to get in the next paper. You're going to have, of course, clinical MCQs, but MCQs that would need skill integrated from multiple branches. Like what you need in this MCQ, you need to know how to read the biopsy, you need to know how to read the X-ray picture, and of course, you need to integrate the clinical history with the X-ray finding and the biopsy finding. And then, first you have to decide upon the diagnosis. Because if this is wrong, the further question becomes wrong. Because only with the correct diagnosis, you will be able to predict about the prognosis. So that is what the next exam is going to be. A clinical question that would span multiple branches, and of course a clinical skill integrated into your academic knowledge. So I'll just tell you how to solve such kind of questions with a very nice approach. All right. So what's my clinical approach in such questions? I always chart down the relevant findings. Age 6 years, mid thigh mass, which means the lesion is diaphyseal. So anything that's not diaphyseal, that goes out. Then fever history is there, ESR is raised. So something that is pointing towards infection, and even if it's a tumor, it has to be something that mimics infection, like Ewing's. And then the X-ray picture. You have a lamellated periosteal reaction plus bone destruction. So destruction itself means the lesion is aggressive. Okay. Now the history just spans over 1 month in the whole scenario. And these are the relevant findings from the history. Now any damn lesion would either be traumatic or congenital or infective inflammatory or neoplastic. These are the only 4 categories that exist where you can group any damn lesion. Now in this lesion there is no history of trauma, nothing like that. So the traumatic lesion is not a possibility. You have this age of 6 years, so something that's congenital, again not a possibility. Okay. So my choice now remains between an infective inflammatory lesion or a neoplastic lesion, and both remain to be a possibility going by this history. So let me now give points to each. 6 years age, so could be both, because infection and neoplasm both can present in this particular age group. Okay. Okay. Mid-thigh diaphyseal mass. So diaphyseal mass I'll give to neoplastic because infections are generally metaphyseal. So infection goes out. 1 month history. If it has to be infection, it has to be chronic osteomyelitis. And if it has to be chronic osteomyelitis, the telltale sign would be a sinus. No sinus is mentioned. So again, this goes towards neoplastic. Fever and ESR raised could be possible in both. So points to both. Anemia. This is generally there in a chronic disorder and could be there in both. So point there to both. Now look at the X-ray. Periosteal reaction can be there in both scenarios. Infection as well as a tumor. Ewing's can also have a periosteal reaction. Infection can also have a periosteal reaction. But mind you, lamellated periosteal reaction, something that you call as the onion peel appearance, lamellated periosteal reaction, that specifically points towards neoplasm. Clear? So now once I finally evaluate the whole scenario, I find more weightage going towards the neoplastic lesion. So Ewing becomes my first possibility and infection goes down the list. But still, if I have to keep a differential, I'll keep both the differentials, Ewing's, but there'll be more chances of Ewing's than the lesion being infective, that is osteomyelitis. But then, when I look at this biopsy, that just clears to me this is Ewing's. So which means I have to see the bad prognostic factor in Ewing sarcoma. So what would be the answer? Let me just brief you on that. This is the X-ray finding that you have in Ewing sarcoma. Look at the amount of periosteal reaction. You find huge amounts of bone formation. And this is actually in layers. First layer, second layer, third layer, fourth layer. So you have bone formation occurring in layers. And perhaps, that's what you call as the onion peel appearance. So that is classical in Ewing's. Now, what do you see in the biopsy? I think that also needs to be pointed out. So I'll just show you the biopsy findings also in Ewing's. So that is how the biopsy in Ewing sarcoma looks like. You typically say that this is small blue round cells. But what you see with them are rosettes. Rosettes are basically those stars that you put on your chest when you attend a conference. So I hope you can see these small blue round cells and the blood vessels in the center, rosettes. In fact, when you don't have a blood vessel, that is a pseudo rosette. When you have a blood vessel in the center, that's a rosette. That is classical what you find in Ewing sarcoma, small blue round cells with rosettes. This is also called as a PNET type biopsy. PNET basically stands for primitive neuroectodermal tumors. So all tumors that arise from neuroectoderm tend to have this biopsy. But mind you, Ewing does not arise from neuroectoderm. It is a tumor arising from marrow. So Ewing's is a mesodermal tumor. But then in this tumor, you have a translocation 11 to 22. And because of this translocation, the biopsy is ectodermal. So basically the biopsy of Ewing's could be the biopsy of lymphoma, neuroblastoma, pineoblastoma, medulloblastoma. Any neuroectodermal tumor can have the same biopsy. So you are supposed to stain this biopsy with tumor markers to decide that you are dealing with a case of Ewing sarcoma, and Ewing sarcoma is CD99 positive and MIC2 gene positive. Only when you have this PNET biopsy positive for CD99 and MIC2 gene, you call this biopsy to be Ewing sarcoma. Otherwise, it could be even neuroblastoma, retinoblastoma, lymphoma, pineoblastoma. They are all neuroectodermal tumors. And yes, regarding the prognostic factors in Ewing's, I must clear to you, distant metastasis is the most important, the main decider, and this is basically related to the stage of the tumor. Mind you, I have not spoken of grade. Grade is basically defined on biopsy, and by convention, all Ewing sarcomas, they are taken to be high grade. There is nothing like a low grade Ewing sarcoma. So stage is the prognostic factor, not grade. Age more than 10 years, increased inflammatory markers, increased LDH levels, history of fever, anemia, they all tend to carry a bad prognosis. And that was perhaps the question we were dealing with. The bad prognostic factors in this case, LDH, yes, this would be recurrent fevers, yes, this would be grade, no. because I've just told you that all Ewing sarcomas, they are high grade. So this remains the answer because this cannot predict the prognosis. Stage would, which means distant metastasis. And yes, age would also be a bad prognostic factor. Okay, so these are all prognostic factors in Ewing's that you see, and that's how you reach the answer. All right, another very nice question. So have a look at this question now. 15 years boy is come to you with the complaint of swelling over his left shoulder. Perfect. Osteolytic lesion is there in the epiphyseal area of the proximal humerus, and something that you can see, stippled calcification. Now surgeon has recommended the biopsy and the biopsy has been done, and this is the report from the pathologist, a mixture of fibrous matrix with some scattered giant cells. And you've been asked about the most likely diagnosis. So this needs that you should know a little bit about the clinical finding of a tumor, a little bit about the X-ray, and of course the biopsy finding. So again, it's an integration of a few branches. So looking at this history, what is the likely diagnosis? So again, I'll first chart down all the important points for you. So epiphyseal lesion has been there, that is mentioned in the X-ray. So I take out fibrous dysplasia and I take out chondromyxoid fibroma, because classically speaking, these lesions would go into the metaphysis. So they are out. So I'm only left with two options. Either it's a giant cell tumor, there are giant cells, or it's a chondroblastoma. So these two things, they basically remain my possibility. Okay. So how do I decide between the two? Now first thing, stippled calcification. Calcification is classical of cartilaginous tumors. Mind you, if you have cartilage lying in the body for a longer while, it would undergo calcification. You would not find calcification until unless it's a cartilaginous tumor. In GCT, you won't be having calcification because this tumor does not rise from chondroblasts. It does not rise from cartilage cells. But yes, if I take chondroblastoma as the option, how do I rule out GCT? Because there are giant cells. Very simple. You just need to know about giant cell variants. So what you need in this particular question are two things. First, why are you saying it is chondroblastoma? Second, why not GCT? So that is how I solve an MCQ. That not only are you supposed to reach a diagnosis, you're also supposed to remove a diagnosis. So I've removed these two things by the fact that they are metaphyseal. So I have to choose between the two. I've picked up chondroblastoma because of calcification, but I have to rule out why it's not GCT because giant cells are classical of GCT. So what I'll do for this, so this is the X-ray, that's stippled calcification in the proximal humerus for the same patient. So what I'm going to do for this, I'm going to think about the giant cell variants. So what are basically giant cell variants? All those tumors that have giant cells on biopsy. So I'm just going to track down this list, and if chondroblastoma fits into the list, that means the answer is chondroblastoma. So that is what I'm going to do. So if you go through this list where you find giant cells on the biopsy, right? Look at this biopsy, look at this cell, multiple nuclei. So that's what a giant cell looks like. So when you track down the list of giant cell variants, up at number 1 comes aneurysmal bone cyst. Then you can also have simple bone cyst. ABC is the closest variant. Then fibrous dysplasia is another important tumor where you can have giant cells. And in fact, this is the commonest giant cell variant. So ABC is closest variant and fibrous dysplasia is commonest variant. Apart from it, chondroblastoma is another possibility where you can have giant cells. And then you have a rare tumor called non-ossifying fibroma. Even here you can have giant cells on the biopsy. And then there's a rare variant of osteosarcoma that is called osteosarcoma with giant cells that can have giant cells on the biopsy. So chondroblastoma can also have giant cells on the biopsy. And chondroblastoma is a cartilaginous tumor. So here you are also going to find calcification. Now epiphyseal lesion, that's chondroblastoma. Calcification, that will be there in chondroblastoma. Giant cells, that will be there in chondroblastoma. And the age group also suits chondroblastoma. So I don't think now I even need to think twice. Then my answer is basically going to be chondroblastoma here. So it's such a simple, diagnosis to reach, provided you approach the things in a nice manner. All right. All right. So no queries till now. Any queries, please post. I can hardly find a query. Tips for next, I'll give in the end. Okay, Masood, I'll just give in the end regarding your tips for next exam. Fine enough. So nothing else in the chat. So I think things are clear enough to you. And before I just move to next question, I'd just like to show the biopsy in chondroblastoma because this also holds MCQ significance. Now, as I told you that chondroblastoma is going to be a tumor from the chondroblast cartilage. And what is specific of cartilage is calcification. The pattern of calcification you find in chondroblastoma, that's basically called as chicken wire calcification. Chicken wire is basically a fence that is used to guard the homes. So this is the biopsy that's giving so much of calcification, that's giving that appearance of a chicken wire fence. And in fact, this biopsy, it was given to us by this person called Codman. He described this biopsy. So many people also call chondroblastoma as Codman's tumor. Please remember that up, because I know you know of something called Codman's triangle that you find in osteosarcoma. So when the examiner asks you which is Codman's tumor, you tend to take osteosarcoma. Please don't make that mistake. Codman's tumor is chondroblastoma because this biopsy that has chicken wire calcification was described by Codman. But I hope you are clear with a very, very crystal clear message from me that if ever you find of calcification in a tumor, it has to be a cartilaginous tumor. Else you are not going to find calcifications. Clear now? Fine. So one last question from my side. All right. Another clinical question, almost a similar scenario as the first question. 12 years old boy. There's a progressive swelling over left proximal arm. So proximal arm means it is epiphyseal or metaphyseal. There are ill-defined margins, which means the lesion is possibly malignant. There are dilated veins present over the swelling. Oh, and the lesion is shown to you. Perfect. So that's the lesion. Oh, that's a huge size, and I hope you can see very clearly the dilated veins over this swelling. Diagnostic feature, these dilated veins, I'll just tell you about them as well. Now the local temperature is mildly raised. CRP is normal. Swelling is mildly tender. In X-rays, you have again laminated periosteal reaction. Metaphyseal lesion, likely diagnosis. So as I always say that whenever I find these kind of questions where there is a likely possibility of an overlap, I always chart down the clinical findings as 1, 2, 3, because this could be Ewing's, this could be osteosarcoma. Very close match. You have laminated periosteal reaction could be there in both. Both can be warm, tender. Dilated veins, although more classical of osteosarcoma, but can be rarely there in Ewing's. Then this age also suits both the tumors. So in this scenario, I always love to chart down my options first so that I can refine my clinical approach. So 12 years boy, that's the age. You have progressive swelling, so which clearly points to you it is malignant. And proximal arm tells you that we are either dealing with a metaphyseal lesion or a diaphyseal lesion. Ill-defined margins clears it's malignant. Dilated veins, I would give it to osteosarcoma. And then CRP is normal and mild tender. Okay, so now I have two queries here. Is it Ewing sarcoma? Is it osteosarcoma? So these are my two differentials. So let me give points to each. Age can be there in both, so I don't give any point to anyone. Progressive swelling can be there in both in proximal arm, possible, because both of them are metaphyseal lesions. Ewing's is diaphyseal. Osteosarcoma is strictly metaphyseal. So osteosarcoma gets a point. Ewing's can be metaphyseal, but largely diaphyseal. Ill-defined margins, both get a point. Dilated veins, osteosarcoma gets a point. Very important. CRP is normal. Ewing's loses a point because in Ewing's fever, high CRP, mimicking infection, very common. And then mildly tender, very important. Osteosarcoma gets a point because when a lesion is mildly tender, it is osteosarcoma. Why? You have infarctions in osteosarcoma, in tumor, that lead to pain. So tender mass is characteristic of osteosarcoma because those microinfarctions that occur in the tumor, they generate the pain. So now when I see the weightage, my likely diagnosis becomes osteosarcoma, and then the X-ray picture, periosteal reaction, bone destruction, further proves this is osteosarcoma. So that now becomes my first diagnosis. And of course, I will show you the classical X-ray signs also. So this triangle that has been formed, this is Codman's triangle. That's labeled in front of you. This raid-like appearance, that sun ray appearance. So these are classical of osteosarcoma, but mind you, they are all periosteal reactions. And in fact, the three important periosteal reactions we have spoken today, sun ray appearance, Codman's triangle, and even the onion peel appearance, they can overlap in both the tumors, Ewing as well as osteosarcoma, but onion peel will be generally characteristic of Ewing's, and Codman's triangle, sun ray appearance, they would generally be more characteristic of osteosarcoma. If we'll see the biopsy in osteosarcoma, that will be diagnostic because all this material that you can see, this is osteoid. And this osteoid is like diagnostic of osteosarcoma on the biopsy. So that is how the biopsy of osteosarcoma looks like. It's very different from Ewing's where you had round cells, rosettes, that PNET type of biopsy. So if these things are given, they can be of additional help. But I hope you could very well make out that the information given in the question was good enough to tell you that you're dealing with the diagnosis of osteosarcoma. Okay, it's not GCT because that will be epiphyseal lesion. All right. Then, in GCT, you would generally not find these dilated veins. They won't be there. All right. And then GCT, this age group will never be there because GCT you generally find in like 20 to 40 years age group, middle age. GCT occurs after the fusion of growth plates. And in 12 years, the growth plates will be open. So I can rule out GCT. And 12 years is no way an age for metastasis. Very rare. So everything points towards osteosarcoma, even here. So that's how I reached the diagnosis. And regarding osteosarcoma, something very, very important I would like to tell you, something very specific of osteosarcoma. This is one of the only tumor where you have bimodal age presentation. You find it in this age group of 10 to 20 years. When it arises de novo, means apne aap arise kar jata hai. And here you basically call it as like primary osteosarcoma. But mind you, this is a tumor that can also be seen in the age group of 40 to 60 years. And here it generally arises in a pre-existing lesion. Like osteoblastoma becomes osteosarcoma, a Paget's disease, you can have secondary osteosarcoma, radiations, too much of X-ray exposure, you can have osteosarcoma. That is basically secondary osteosarcoma. So that is very, very classical of this tumor. It's perhaps the only bone tumor that has a bimodal age distribution. And yes, a word about various types of osteosarcoma. The classical osteosarcoma would begin in the metaphyses in the medullary canal and then spread out. That will be the classical pattern, breaking the cortex, going on to involve the soft tissue. But you also have a variant called surface osteosarcoma that begins on the cortex and relatively a very aggressive tumor. But you also have a telangiectatic variant where you have a ballooned appearance like an aneurysmal bone cyst, and this is like very lethal. So these are some of the variants of the conventional osteosarcoma that you need to know. And yes, a word about the treatment of osteosarcoma. Well, in osteosarcoma, the first word that comes to my mind is always amputation. Because let me tell you, this is the most radio resistant tumor. This is the most chemo resistant tumor. And then let me tell you, this is the most radiation induced bone tumor. मतलब रेडिएशन लगने से भी जो सबसे कॉमनली ट्यूमर होता है, that is osteosarcoma. So it's a tumor that has a bad prognosis. So many surgeons straight away love to go with amputation. But what has happened now that with such a good chemotherapy, the concept of limb salvage has also come into practice. So here what we do, we first go with neoadjuvant chemotherapy. Then we follow it up with a radical excision of the tumor. Radical excision means we excise the whole compartment that has the tumor. पूरा का पूरा compartment निकाल देते हैं. And then, along with it, after removing so much of bone, we are supposed to use a mega prosthesis. What's a mega prosthesis? I'll just show to you. So here I've removed the complete thigh, radical excision. I've removed the complete thigh and I've replaced the whole bone with a prosthesis that has the hip joint as well as the knee joint. So when you replace more than one joint, the hip and the knee, that's a mega prosthesis. A simple prosthesis would have just one joint. But when you have more than one joint in the prosthesis, this is a mega prosthesis. And yes, this would be finally followed by a cycle of final chemotherapy. So this will be the limb salvage surgery that is now becoming popular in case of osteosarcoma. So you first go with neoadjuvant chemo, then you go with radical excision and you fit in your mega prosthesis, and then you take up the final cycle of chemotherapy. And T10 protocol is like the conventional protocol for osteosarcoma, where you go with high dose methotrexate, vincristine, and bleomycin cyclophosphamide doxorubicin. Although this is a very chemo resistant tumor, but still you have to do your best, and that's the best you get. So that's all about the three important tumors. And just as I end up, just a few high yield points. If you would ask me the commonest tumor of the bone, let me tell you, it's actually the metastasis. Means इधर उधर का tumor bone पे आ जाता है, metastasis. But yes, if you ask me the commonest primary tumor of bone, I would say that's multiple myeloma. That's the commonest tumor of bone itself. But that's a malignant tumor. So if you're going to ask me the commonest benign tumor of bone, then the answer will be osteochondroma. A tumor that you guys more popularly call it as exostosis. But then exostosis, some people say it's a growth aberration, an abnormal growth from the growth plate. So sometimes examiner uses this word true, commonest true benign tumor. So when this word true has been used, then the answer changes to osteoid osteoma. And yes, sometimes just simply ask the commonest lesion of the bone. Lesion would be something where there is no metastasis, जो फैलती नहीं है, जो अपनी जगह पे रहती है. That is a tumor-like lesion, not a tumor. So when you are asked the commonest tumor-like lesion, the answer becomes fibrous cortical defect. So these are some of the most common from the field of the bone tumors. Sometimes they can just be MCQs in your exams. So please just mark them up. The commonest tumor of the bone is actually metastasis. Commonest primary tumor limited to bone is multiple myeloma. The commonest benign tumor would be osteochondroma exostosis. The commonest true benign tumor will be osteoid osteoma, and the commonest lesion of the bone will be fibrous cortical defect. So that's all from this class. You wish to attend more such free classes, you can attend on Unacademy. In case you wish to find me, then I'm giving you my Telegram group link, t.me Dr. Mukul Ortho. That's the link for my Telegram group. In case you wish to find me on Facebook, then that's the name of my profile, Mukul Mohindra Ortho. A good idea would be to join the Telegram group because I'm in a habit of posting daily updates, MCQs, answering your queries. In case you wish to attend my free classes on Unacademy, then I generally take free classes on Thursdays and Sundays. You can check out the schedule at that time. And yes, in case you wish to stay in touch with me, the best way, take a subscription and just use this code Dr. Mukul-YT to get your 10% off. The prices are very, very economical. Like even if you take a subscription for 6 months, it's just 18,000, and this includes all subjects and number of classes, whatever you wish to see. That's there on the platform. And yes, Unacademy now also has the Iconic Plus subscription because Unacademy is now connected with Prep Ladder. So you can buy both also at very, very economical prices if you wish to. So you have the live lectures with you as well as the recorded versions. That's all from my side. And in the end, as I say thank you to you, a word about how you are going to study for the next exam. This is a textbook that's been written by me, a lovely book. So people in the early part of their career, just go with this textbook. You won't even need to touch an MCQ book. It has everything in a very simple language. And this is an MCQ book written by me. You can go with this MCQ book if you're in the final stage of the career, like you're preparing for your NEET PG. So just attend the lectures at Unacademy, go through the notes, and practice MCQs from this MCQ book. That'll be enough for your NEET exam coming in January. Any queries, guys? Any queries? Okay, so you're joining MBBS in Bangladesh this year. So you asked me the tips for next exam. I just have a single tip for you in the end. Make sure you have good basics. I cannot say that what will be the scenario when you will be giving your next exam, what the rules would be like. The rules in India are drastically changing. Next was never on the cards, but it has come up. Institute like AIMS, they have some seats reserved for the foreign graduates. So maybe you'll be able to cash on them when the time comes nearby. But no point of thinking about all such things at present. At present, you should have just one thing in mind: to have the best of knowledge, to have the best of the concepts. So I hope no other queries. Fine enough, guys. So I'll just close up the session. Hope you enjoyed the class. For more classes,